I had a knee reconstruction which consisted of resurfacing of 2 areas of my knee and a replacement of my ACL, a previous ACL that had been put in about 18 years ago.
Knee resurfacing is part of a spectrum of treatment for knee problems. The early part of the spectrum would be biological knee replacement, and then as patients get a little bit older and the problems get more advanced, let's say, then we can resurface the knee. And this is an alternative to knee replacement in certain cases where the knee still has healthy parts. In the situations where the knee is entirely worn out, knee replacement may well be appropriate, but in many patients, especially some of the active patients we see here in Park City, the knee has healthy parts, it has healthy ligaments, and in doing knee resurfacing we can preserve those, which maintains a patient's sense of normalcy in the knee.
I was experiencing pain in an increasing manner during a number of the exercises and activities that I enjoy doing: biking, cross-country skiing, and alpine skiing. And after going through a number of alternatives, including several injections which were not providing any relief, I contacted Dr. Davidson.
When you do a knee replacement, you cut off quite a bit of bone, and the patient loses much of the sense of position, the subtle capacity to change direction and do some interesting and athletic activities can be lost with a knee replacement. And with knee resurfacing, we can alleviate or relieve pain, we can improve their function, and many times retain a higher level of function because we're preserving normal cartilage, normal bone, and normal ligaments with knee resurfacing.
He determined that resurfacing was appropriate. We did an MRI, and it revealed damage to the cartilage in my knee and under my kneecap, as well as the fact that my old ACL was not in good shape or working properly.
So this is a plastic model of a knee which has been resurfaced, and this is in fact exactly what Jonathan's knee looks like. This is the area, well, first of all, the white covering or the white lining of the bone is articular cartilage, and the articular cartilage in his knee was worn in this area, and we replaced it with this metallic, we call it an inlay arthroplasty, an inlay prosthesis. And the analogy I make to the patients is it's much like if you have a bad tile or maybe 2 bad tiles on your floor, rather than ripping out the floor and the foundation, which would be like a total knee replacement, we're able to selectively replace tiles. And so this, if you see it from a side profile, forms a perfect congruity, and we're able during the surgery to make what I call a topographic map, and we can restore the surface and it's perfectly flush. He also had an implant put on the inner side of his knee. This is a second inlay, and in this particular example you can see these aren't very big, but they replace the part where he's missing the articular cartilage and allowed, in his case, room. He has a new ACL graft, and in conjunction with these, they don't interfere with, but rather facilitate and allow. The ACL graft goes in here, and he has a new ACL in addition to these resurfacings. So not only is his knee now going to be stable and allow him to do more things with better security, but he should get good pain relief from having resurfaced these raw areas in his knee. There are patients that need a total knee replacement. These are patients in whom the entire knee, the knee has 3 parts, and then there are ligaments. In patients that have ligament damage and damage in all 3 parts and really extensive disease of the knee, knee replacement is very appropriate and is a great operation in those instances. However, some people, and in fact many people, have preserved and healthy parts of the knee, whereupon we can just resurface or replace individual parts. It's a very specific approach. It's a patient-specific approach, and each case differs. In Jonathan's situation, he had a ligament deficiency for many years, so his knee was unstable, as well as 2 of the 3 parts of the knee had areas where the cartilage was lost. So he was suffering from bone-on-bone pain as well as instability, yet he still did have some good ligament in the knee, or some good ligament structure in the knee, and he had one part, the outer or lateral part, was entirely healthy, and so we were able to save that.
Well, I'm still 4 weeks out, and my rehab is limited by the new ACL. However, the knee appears to be and feels as though it's tracking in a much straighter manner. It's definitely stable. When I walk, I feel that the leg is going more in the direction that I want to go as opposed to wandering in its own direction a little, which I had before, which I guess would be instability. The pain is right now, I take a couple of Tylenol at night to make sure it doesn't bother me, and that's it. I don't take any other medications for it. Pain has not been a problem for the last several weeks.
Many people are looking for alternatives, and in lots of patients this is an excellent alternative, although I want to emphasize this is not for every person as much as I treat knees in a continuum or a spectrum. And a knee replacement, I do knee replacement, but there's lots of options, and we explore those each and every case.